Upper respiratory tract is one of the most common sites of infection in clinical practice, affecting millions of people worldwide each year. Let's begin by understanding the different types of upper respiratory tract infections. First is rhinitis, which is inflammation of the nasal mucosa. This is commonly known as the common cold, and is what we experience when our nose becomes congested and runny. Pharyngitis is a throat infection, which involves inflammation of the pharynx and typically presents with a sore throat. Sinusitis is inflammation of the paranasal sinuses. The sinuses are air-filled spaces around the nasal cavity that can become infected and filled with fluid. Tonsillitis, which specifically involves inflammation and infection of the tonsils, the lymphoid tissues at the back of the throat. Laryngitis is inflammation of the larynx. Patients with laryngitis typically present with hoarseness or loss of voice. Acute epiglottitis, a potentially life-threatening condition involving inflammation of the epiglottis, the cartilage that covers the windpipe during swallowing. Finally, otitis media, which is infection of the middle ear space. While anatomically the ear is separate, it's connected to the upper respiratory tract via the eustachian tube, which is why ear infections often accompany upper respiratory infections. Understanding these different types is crucial, as each has specific causative organisms and clinical presentations. This diagram illustrates an important concept. The respiratory tract functions as a continuum. What does this mean? The respiratory tract is anatomically and functionally continuous, from the nose and mouth, all the way down to the alveoli in the lungs. Infections don't respect arbitrary anatomical boundaries. An infection that starts in the upper respiratory tract can easily spread downward to involve the lower respiratory tract. This continuity explains several clinical observations. For example, a simple viral rhinitis or common cold can progress to involve the pharynx, causing pharyngitis. The infection can then descend to cause laryngitis or tracheitis. In severe cases, particularly in children or immunocompromised individuals, the infection can progress to bronchitis or even pneumonia. This concept is particularly important when we discuss conditions like croup, or laryngotracheobronchitis, where inflammation extends from the larynx through the trachea to the bronchi. Understanding this anatomical continuum helps us anticipate potential complications and understand why certain infections tend to occur together. The shared mucosal lining throughout the respiratory tract also means that similar defense mechanisms operate throughout, including mucus production, ciliary action, and local immune responses. This comprehensive table summarizes the major infectious causes of URT infections. For rhinitis, the most common cause is rhinovirus, which is an RNA virus responsible for about half of all common colds. Coronavirus, also an RNA virus, is another important cause. Adenovirus can also cause rhinitis, often with more systemic symptoms. Pharyngitis and tonsillitis have both viral and bacterial causes. Viral causes include adenovirus, Coxsackie virus, Epstein-Barr virus, which causes infectious mononucleosis, and parainfluenza virus. The most important bacterial cause is Streptococcus pyogenes, also known as Group A Streptococcus, which causes strep throat. Corynebacterium diphtheriae, though now rare due to vaccination, causes diphtheria. For sinusitis, viral causes include influenza virus, rhinovirus, and coronavirus. Bacterial causes include Streptococcus pneumonia, Haemophilus influenzae, Moraxella catarrhalis, and Staphylococcus aureus. Often, sinusitis begins as a viral infection and becomes secondarily infected with bacteria. Laryngitis is primarily caused by parainfluenza virus, influenza virus, and adenovirus. Haemophilus influenzae can occasionally cause bacterial laryngitis. Acute epiglottitis, a medical emergency, is most commonly caused by Haemophilus influenzae, though its incidence has dramatically decreased since the introduction of the Hib vaccine. Other causes include Streptococcus pneumonia and Corynebacterium diphtheria. Finally, otitis media can be caused by parainfluenza virus, but bacterial causes are more common, including Streptococcus pneumonia, Staphylococcus aureus, and Haemophilus influenzae. Notice that most upper respiratory infections are viral in origin, which is why antibiotics are not always necessary. Let's apply our knowledge to a clinical case. A 7-year-old child presents with a sore throat, fever, and difficulty swallowing. These are classic symptoms of pharyngitis. On examination, the pharynx looks congested, meaning it appears red and inflamed. There's tonsillar erythema, which means the tonsils are red, and exudates, which are white or yellow patches of pus on the tonsils. This combination of findings is highly suggestive of bacterial pharyngitis, specifically streptococcal pharyngitis. An important clinical observation is that the child does not have a cough or runny nose. This is a key distinguishing feature. Viral pharyngitis typically occurs as part of a viral upper respiratory infection, with other symptoms like cough, runny nose, and conjunctivitis. The absence of these features makes bacterial pharyngitis more likely. This clinical presentation is classic for strep throat, caused by Streptococcus pyogenes. The presence of tonsillar exudates, fever, and absence of cough are part of the CENTOR criteria, which help clinicians predict the likelihood of streptococcal pharyngitis and guide decisions about whether to perform rapid strep testing or prescribe antibiotics. Why is it important to identify streptococcal pharyngitis? Because untreated strep throat can lead to serious complications, including acute rheumatic fever, which can cause permanent heart valve damage, and post-streptococcal glomerulonephritis, which affects the kidneys. Therefore, accurate diagnosis and appropriate antibiotic treatment are crucial. Pharyngitis typically affects the oropharynx, where we find abundant lymphoid tissue including the palatine tonsils, which are the tonsils we can see when someone opens their mouth wide, and the pharyngeal bands, which are streaks of lymphoid tissue on the posterior pharyngeal wall. Pharyngitis can be caused by both bacteria and viruses, though most cases are viral. The most important bacterial causes are Streptococcus pyogenes, which causes the classic sore throat we discussed in our case, and Corynebacterium diphtheriae, which causes diphtheria. While diphtheria is now rare in countries with good vaccination coverage, it remains a serious disease where it occurs. Viral causes are numerous and include adenovirus, which often causes pharyngoconjunctival fever with sore throat, red eyes, and fever. Coxsackie virus causes herpingioina, characterized by small vesicles and ulcers in the throat. Parainfluenza viruses and influenza viruses can cause pharyngitis as part of a broader respiratory infection. Epstein-Barr virus causes infectious mononucleosis, presenting with severe pharyngitis, enlarged tonsils often with exudates, generalized lymphadenopathy, and fatigue. Understanding the anatomy helps us appreciate why pharyngitis causes pain with swallowing, as the pharynx is involved in the swallowing mechanism. Streptococcus pyogenes must first adhere to the pharyngeal epithelium to establish infection. It does this using three main adhesion molecules. First is M protein, which is a major virulence factor that projects from the bacterial surface like tiny hairs. M protein not only helps the bacteria stick to epithelial cells, but also inhibits phagocytosis, helping the bacteria evade the immune system. Second is lipoteichoic acid, which is a component of the bacterial cell wall that facilitates initial binding to epithelial cells. Third is fibronectin-binding protein, also called protein F, which binds to fibronectin on host cells, providing strong adhesion. Once adhered, the bacteria multiply and cause inflammation of the oropharynx, particularly affecting the soft palate and tonsils. The immune response to the infection causes vasodilation and increased vascular permeability, leading to the characteristic redness or erythema we see on examination. The inflammatory exudate, composed of white blood cells, fibrin, and dead bacteria, accumulates on the surface of the tonsils, creating the yellow-white exudate we observe clinically. This exudate is pus, and its presence on the tonsils is a hallmark of streptococcal pharyngitis. The infection spreads from person to person through respiratory droplets. When an infected person coughs, sneezes, or even talks, tiny droplets containing the bacteria are expelled into the air and can be inhaled by others or land on surfaces that others touch. The cervical lymph nodes that drain the pharyngeal area become swollen and tender as they work to filter and respond to the infection. This is why patients with strep throat often have tender, enlarged lymph nodes in their neck. A pharyngeal swab should be taken, and importantly, it must include both tonsils. The swab should be rubbed firmly over both tonsils and the posterior pharyngeal wall to collect adequate material. Avoid touching the tongue, cheeks, or lips, as this can contaminate the sample with normal oral flora. For culture, the material on the swab is inoculated onto blood agar plates. After incubation, the image shows beta hemolysis produced by Streptococcus pyogenes. However, culture takes 24 hours for results. For more rapid diagnosis, we use rapid antigen detection tests. These tests directly detect Streptococcus pyogenes antigen from the throat swab within 5 to 10 minutes. Diagnostic kits use specific antibodies to detect the group A carbohydrate antigen, which is unique to Streptococcus pyogenes. The test uses enzyme immunoassay or agglutination techniques. Enzyme immunoassay tests are more sensitive, detecting about 90 to 95% of cases, while agglutination tests are slightly less sensitive but faster. The advantage of rapid tests is that treatment decisions can be made during the patient visit. However, negative rapid tests in children should be confirmed by culture because of the risk of false negatives and the serious complications of untreated strep throat. Let's see another case. A 4-year-old boy is brought to the emergency department with fever and difficulty breathing. Immediately, the combination of these symptoms in a young child raises serious concern. On examination, the child is in respiratory distress, possibly using accessory muscles, or showing signs like nasal flaring or intercostal retractions. This indicates significant airway compromise. The key finding is in the oral cavity. A grayish membrane is noted covering the tonsils and pharynx. This is the hallmark of diphtheria and is called a pseudomembrane. Along with the membrane, there's severe pharyngeal inflammation and swelling. Cervical lymph nodes are palpable, meaning they're enlarged and can be felt on examination. In severe diphtheria, the neck swelling can be so pronounced that it's called bull neck appearance. This clinical presentation is highly suggestive of diphtheria, caused by Corynebacterium diphtheriae. Diphtheria is now rare in countries with comprehensive vaccination programs, but it remains a serious disease where it occurs, particularly in unvaccinated or inadequately vaccinated children. The respiratory distress in this case is concerning because the pseudomembrane can extend into the larynx and trachea, potentially causing complete airway obstruction. Additionally, diphtheria toxin can cause serious systemic complications, including myocarditis, affecting the heart, and neuritis, affecting peripheral nerves. This case is a medical emergency requiring immediate intervention, including securing the airway, administering diphtheria antitoxin, and antibiotic therapy. The presence of the characteristic pseudomembrane makes the clinical diagnosis, though laboratory confirmation is important. The pseudomembrane is the most characteristic feature of diphtheria. Diphtheria toxin is the key virulence factor of Corynebacterium diphtheriae. This potent exotoxin has both local and systemic effects. Locally, the toxin causes tissue damage through its cytotoxic effects. The toxin elicits an inflammatory response at the site of infection. As epithelial cells die from the toxic effects, an intense inflammatory reaction occurs. This leads to necrosis of the epithelium. Simultaneously, there's exudate formation and proteins from blood vessels into the tissues. This process leads to the formation of mucosal ulcers, which are then lined by a tough, leathery, grayish-white pseudomembrane. It's a mixture of dead epithelial cells from the destroyed mucosa, fibrin from the coagulation cascade activated by tissue damage, red blood cells that have leaked from damaged vessels, WBCs that have migrated to fight the infection, and the organisms themselves. A critical characteristic of this pseudomembrane is that it's firmly adherent to the mucosal base. This distinguishes it from the exudates seen in streptococcal pharyngitis, which can be easily wiped away. When you attempt to remove the diphtheria pseudomembrane, it bleeds because removing it tears the underlying damaged tissue. This bleeding on attempted removal is a diagnostic sign. The photograph shows the characteristic thick gray membrane covering the posterior pharynx. Notice how it forms a confluent coating over the tonsils and pharyngeal wall. This membrane can extend to cover the uvula, soft palate, and can extend downward into the larynx and trachea, causing potentially fatal airway obstruction. Sample collection requires a throat swab, and, if possible, a portion of the pseudomembrane itself should be collected. The specimen should be collected from beneath the membrane at the edge where it meets healthy tissue, as this is where organisms are most numerous. Special staining is important for rapid preliminary diagnosis. Albert stain is a special stain that demonstrates metachromatic granules, also called volutin granules or Babes Ernst granules. These are polyphosphate storage granules within Corynebacterium diphtheriae that appear as dark blue or purple dots at the poles of the bacteria, while the bacterial body stains lighter. This gives a characteristic beaded appearance. The presence of metachromatic granules is suggestive, but not definitive for C. diphtheriae. For culture, Loeffler's medium-containing serum that allows for rapid growth of Corynebacterium diphtheriae. Growth occurs within 6 to 8 hours, much faster than on other media. On Loeffler's medium, colonies appear opaque and gray-white in color, as shown in the image. The second type of medium used is selective media tellurite agar. This medium is selective because potassium tellurite inhibits the growth of most other bacteria, allowing Corynebacterium diphtheriae to grow preferentially. A remarkable characteristic on this medium is that Corynebacterium diphtheriae reduces tellurite to tellurium, which has a distinctive appearance. The colonies develop a typical gray-black color due to the intracellular deposition of metallic tellurium. This black color is a telltale diagnostic criterion. Not just isolating Corynebacterium diphtheriae from a patient definitively prove they have diphtheria disease. Why? Because some strains do not produce toxin and are therefore not pathogenic. The disease diphtheria is caused by the toxin, not merely by the presence of the bacteria. Therefore, we must demonstrate that the isolated organism produces diphtheria toxin. In the ELIC test, a sterile filter paper strip impregnated with diphtheria antitoxin is embedded in agar culture medium. Isolates of Corynebacterium diphtheriae are then streaked across the plate at a 90-degree angle to the antitoxin strip. If the organism is toxigenic, meaning it produces toxin, the secreted toxin diffuses outward from the area of bacterial growth. This toxin then reacts with the antitoxin diffusing from the filter paper strip. Where toxin meets antitoxin in optimal proportions, they form lines of precipitin, which appear as white precipitate lines in the agar at a 45-degree angle to both the bacterial growth and the antitoxin strip. General preventative measures include careful hand washing, which is one of the most effective ways to prevent transmission of respiratory pathogens. Additionally, chlorination of swimming pools can reduce transmission of pharyngitis, as contaminated water can be a source of infection. For Streptococcus pyogenes pharyngitis, the organism is highly sensitive to penicillin. Penicillin remains the treatment of choice after more than 70 years of use, and remarkably, Streptococcus pyogenes has not developed resistance to penicillin. For patients with a history of penicillin allergy, cephalosporins can be used as an alternative. First-generation cephalosporins like cephalexin are effective. It's important to note that there is currently no vaccine available against Streptococcus pyogenes, despite decades of research. The challenge is that there are over 200 different M protein types, and immunity to one type doesn't protect against others. For Corynebacterium diphtheriae, the treatment approach is different and urgent. The treatment of choice is diphtheria antitoxin, which is horse serum containing antibodies against diphtheria toxin. This must be administered as early as possible because it only neutralizes circulating toxin that hasn't yet bound to cells. Once toxin binds to cells, antitoxin cannot reverse the damage. Antibiotics, typically penicillin or erythromycin, are also given to kill the bacteria and stop further toxin production. But antibiotics don't neutralize existing toxin. The vaccine contains diphtheria toxoid, which is inactivated toxin that stimulates immunity without causing disease. This is part of routine childhood vaccination schedules worldwide.